Thank you, Katerina, for your words, kind words. Hello, everybody. I would like to take the opportunity to thank Manuel Antonjanakis and Manuel Brilakis for the opportunity to be here and publicly enhance their capacity and resilience to put together an event like this. It's outstanding. Congratulations. I'm going to explain to you my way of treating the subscapular tendon tears. I try to be didactic. I use the classification by Lafosse, and 1 and 2 are, 1 is partial lesions, 2 complete lesions, and then they aggravate accordingly. And we are not going to speak about the type 5 complete lesions with a stage 3 fatty degeneration. We are only going to speak about the first 4 types. I use the bead shape position, normally interscalenic block with a great control of the blood pressure in order to have the less bleeding facility that I can manage. Then I will have to classify my lesion when I look at it. And if I have a partial lesion or a complete lesion of the superior third, I advise you to have in good consideration the clinical exam of the patient. If it is a traumatic inset or a non-traumatic one, if the tests for the subscapularis are positive or not positive, that makes a difference. And if the complaints are more of the long head of the biceps due to instability of the long head of the biceps, due to the damage of the anterior pulley, because this will put you on a decision track that will most likely, if you get careful, will do the best decision for you. Because if you have complaints more of the long head of the biceps due to instability, most likely perhaps the only thing that you need to do is to take care of the long head of the biceps the best way you think it's applicable for this patient, or if you have complaints due to the lack of strength of the subscapularis, perhaps you need to repair a type 2 lesion. So sometimes you need to address only the long head of the biceps. Sometimes you need to address the subscapularis in order to have the good result. I'm only speaking about 1 and 2 types of lesions. Remember that the type 1 maybe is only a degenerative change that you are looking at, but has no implication of the clinical picture of the patient. So perhaps consider it, leaving it alone if the clinical picture is not in favor of the lesion. Of course, if you have the others 2 types of lesions, you'll have to have other considerations. I normally use a posterior portal to begin with, as usual, and then I use an external portal and a supralateral portal. And of course, I need some other portals in order to achieve the best reduction and the best position of my anchors. I advise you to debride as much bursa as you need in order to have a clear view of your cuff. And then you should address long head of the biceps stability and quality and act accordingly, meaning that if you have a degenerative long head of the biceps in the intra-articular part of the long head of the biceps, most likely you should not do an intra-articular procedure because you'll end up with a tendon with bad quality, and you need to go to the bicipital groove and do, if this is a good technique in your hands, for instance, an interference screw or other techniques that you can use on the bicipital groove. On the intra-articular part of when I address the long head of the biceps intra-articularly, I normally do 2 lasso loops with an anchor, taking good care into abrading the hard bone of the bicipital groove, and I use normally my pilot hole of the anchors. I do multiple hammering of the groove in order to get bleeding, in order to get a good a good cicatrization of the long head of the biceps. We are now continuing with general principles. I normally use in type 3 and type 4 the traction sutures in order to be able to control the tendon and to help me on the release of my tendon. I try to use secure fixation suture like the lasso loop that you have here, the example, but also I use Mason Allen modified stitches in order to get my reduction. I must say to you that it's rare for me to use a double row configuration for the subscapularis. In type 1 and type 2 ruptures, I normally treat them looking from the posterior portal. I don't have access to 70 degrees arthroscope, and so if I need to see better, I need to go to the subacromial space. But normally I only need to do this in the type 3 and type 4 ruptures, not in type 1 and type 2. So I use normally a traction instrument in order to reduce, as you can see there, to reduce my tendon, and then I pass my sutures and I decide the best configuration to give me the strongest reduction and to have the most mechanical strength in my reconstruction. In here, normally I don't use traction sutures. I use a traction instrument in order to reduce my tendon. That's completely different if I have to deal with type 3 and type 4 ruptures. Here, as you can see, I have to liberate my tendon. I have to use traction sutures in order to reduce also my tendon. And normally I tend to go to the subacromial space in order to have a good visualization of my tendon. And then I go from the subacromial space, from the dorsal space to the intra-articular space to do my sutures and to tie my knots in order to achieve the best reduction possible. And I use as much anchors as I need to reduce my tendon. As a take-home message, I would say that use intra-articular view for type 1 and type 2. You don't need to go subacromial normally, but you need to go subacromial to use if you are addressing a type 3 or a type 4. You should place, of course, your anchors to reduce your lesion, so you have to use traction instruments or traction sutures in order to see the best reduction for your tendon, and then put your anchors accordingly. Use suitable techniques that you may choose from your portfolio for a footprint reconstruction of your tendon, and of course assess long-headed bicep stability and quality. Remember that in some type of ruptures, type 1 and type 2, perhaps the only thing you need to do is to address the long head of the biceps. You don't need to do anything else. You should address the long head of the biceps accordingly to the quality of the tendon and, of course, the instability of the tendon. And you should do it intra-articular or into the groove, depending on the situation that you have. But remember to keep it simple. Remember your limitations as a surgeon. Remember that it's better to do well what you are used to do than to go to something that is not perfectly correct in your hands. And thank you very much.